Hi, this is Eric Prystowsky, and welcome to another segment of EP on EP. With me today is Dr. Wendy Tzou, who is the Associate Professor of Medicine at the University of Colorado and Associate Director of the EP Laboratory or Program or something like that. Anyway, Wendy is really an outstanding electrophysiologist, and she's called out an area that I think is quite important for all of us. And I'll start with a quote, Wendy, from Shakespeare, from Lady Macbeth. And she talks about, look like the innocent flower, but be the serpent under it. Of course, this is not what I want you to do, but you work in an area where we have a problem, right? Cardiac sarcoid. I know a bit about it because I trained at Mount Sinai where there was a lot of sarcoid, and for my entire career, I've worried about this. How do you know if somebody has cardiac sarcoid? Let's start with the most simple things. You know, you get a CMR report back and it says, rule out cardiac sarcoid. What do you do?
Well, it's a great quote to describe cardiac sarcoidosis because it truly is a confounder, both in terms of being able to diagnose it appropriately as well as to know exactly how to manage it. And it's true that the diagnosis eludes us a lot of times. And you know, your question with regards to finding or getting that report on a cardiac MRI is telling in some way. It means that there was some reason that you wanted to get a cardiac MRI. So if it were because, for instance, the patient presented with heart block and you didn't know why, and you were suspicious about an infiltrative process, then in that setting, you know, a read that identifies an area of, say, delayed gadolinium enhancement in the septal region where, you know, sometimes sarcoid goes. But honestly, sarcoid can go anywhere. But if you have those things in conjunction, I think that you have a stronger case to make for that. But it's not definitive. You know, that's just one sort of modality with which to make the diagnosis. Ultimately, I mean, if you had to have had a reason to have gotten the cardiac MRI, so it was syncope, a low EF, something like that. Any of those features that go along with the cardiac MRI finding and the interpretation, you kind of have to pursue it a little bit further, I think. Okay. When possible, I mean, tissue diagnosis is preferred. That doesn't have to mean native cardiac biopsy, you know. Sometimes that's the only manifestation. Okay. But I think I would start, and what we often do is start with like more global imaging to look for lymph nodes, for instance, mediastinal lymphadenopathy, see if we can get at least tissue diagnosis that can be acquired with lower risk. Okay. You know, and if you have granulomatous disease that's identified there and no other potential cause for that, then I think that that plus the imaging finding plus whatever clinical scenario led to you getting the imaging are suggestive, you know, would make, in fact, a probable cardiac sarcoidosis kind of diagnosis. Other things that can potentially be done to risk stratify, sometimes PET scanning can be useful. You know, cardiac MRI is really good for picking up sort of the more advanced stages of that process where scarring has actually happened. But we recognize too that there's a whole inflammatory component that won't necessarily be seen as easily on cardiac MRI, and that's maybe a little bit easier to detect on PET scanning. That's not perfect either. So it's a lot of, just like with a lot of kind of screening tests that we do to try to make diagnoses in other areas, like ischemia, for instance, stress testing in that circumstance. It's nothing is perfect. Nothing is 100%, except perhaps for tissue diagnosis.
I was surprised by a recent publication from, I believe, somewhere in Europe or maybe Scandinavia, where they suggested 40 or 50% of their cardiac sarcoid was isolated. Now, that's not how I grew up, but do you remember that report?
I do, yeah.
So that's really, that's even more problematic for us, right? So now you get back a report, and I used to send them off to pulmonologists and things like that. Right. And so what do you do with someone like that, where let's say you do get a lesion? Let's say you did it because the person had a slightly dilated ventricle, or who knows, they were going for an AFib ablation, and you get back some spot. Do you pursue that with a biopsy if nothing else is there, or just leave it alone?
I mean, again, it kind of depends on what led you getting the study. If this were an incidental finding that was discovered in the process of pursuing something else or preparing for a procedure, for instance, I would say I would do a lot of other things before I'd pursue a biopsy. But if it were symptoms, unclear near syncope, palpitations, or you do a Holter, say they have like a fair amount of non-sustained VT.
Then you would maybe do even a cardiac biopsy.
Might, yeah. Other things to do, like in advance of that, might be, an EP study voltage map. The voltage map kind of characteristics can provide some information about, can maybe corroborate what was seen on the MRI. Like if you have seen something on the septum or even in the LV, on the endocardium, we don't routinely do voltage maps of the LV without other good reasons.
Okay.
But say if you theoretically did that and it collaborated with this area of abnormality that was seen.
So
on
you
imaging,
do whatever you
then,
can, but you may get to a point where you just sort of say it could be, right? So let's talk about ICDs then, because I know there's a big argument on this, and you guys have a lot of experience. So when do you decide, I don't mean the obvious one who's had a cardiac arrest, when do you decide when the person's not had a major event that you're going to give a primary prevention ICD?
Yeah, that's always a hard question, and everyone's level of risk that they want to accept with regards to sudden death that's unclear down the line is different. One way that we have done at our institution is to perform EP studies, to try to...
You do use EP studies. It's pretty controversial.
We do. It is. It is. There's some reasonable data, in a moderate-sized series to suggest that if it's usually more helpful or useful in people who have also a low EF.
Right.
But even in the case of people who have a normal EF, we have shown at our institution if you have probable cardiac sarcoidosis as identified by imaging and some sort of extra cardiac biopsy proof, and you're inducible, then you're much more likely to go on to have an event, even in the absence of overt LV systolic dysfunction. It's not so helpful if it's just a possible thing. Like if all you have is an imaging thing and you do an EP study, it's not that helpful. So in those people, we kind of just...
So I understand that side. Are you comfortable, take it two of them real quickly. One is a normal heart, normal LV function, other than you have something you think is cardiac sarcoid in there. And the other is someone with, I guess, a low EF. You're probably, regardless of the EP, going to wind up, right? So let's take the harder one. So let's say you don't have a low EF. Let's say your EF is 50%, kind of decent EF, and you have this thing you think is cardiac sarcoid, and you do an EP study and you have non-inducible VT, then I assume that means you won't put in an ICD.
Well, so if we're pretty sure about the diagnosis, they have some sort of conduction disease abnormality.
Let's make it like, let's give you have cardiac sarcoid.
Okay, so you've got it
out.
And the EF is not low.
Right.
There is good data to show that if you have on cardiac MRI regions of scarring, and this is kind of like a burden-based sort of increase in risk, that your risk of developing a ventricular arrhythmia or even dying suddenly is much higher than if you don't. So we kind of can use that as a tiebreaker, in the instances that the EF is normal or just
I'm guessing more often
normal.
than not they get an ICD.
Yeah.
Is that fair to say?
Especially if they have another pacing indication. If, for instance, they have, high-grade AV block.
So if you need if you need metal, you're going to get an ICD. Is that fair?
Yeah, I think
All right.
that's
One
fair.
last thing, because we don't have tons of time. I'd love to keep going, but when you do get to an ablation, let's argue that you've decided to, do you pretty much get ready for an epicardial as well as endo? I mean, what's been your experience?
Yeah, mentally, you kind of prepare the patient for that, and you prepare for that. You may not be able to get to it in the same case, to be honest, because sometimes there's so much to do on the endocardial surface that you just have to stage the procedure for safety purposes and longevity and all that.
I hear you.
Sometimes it involves just the septum, in which case going to the epicardium isn't useful at all. And in many of these cases, they're tough mid-myocardial things where we have to try to talk about using alternative ablation delivery techniques.
And I know you've used that double catheter technique.
Yeah, bipolar ablation, or at our institution, we have developed and use pretty routinely half-normal saline irrigant, as a means to create deeper RF lesions in those cases.
Wendy, this has been great. Thank you for joining us today. This is a tough area. I struggle with every patient I get with cardiac sarcoid, frankly, because if they have a decent ventricle function, there's always the question, I might be missing something. I'd hate to get that call from the mom or dad or wife or something that so-and-so's passed away. I struggled with this my whole career. So this has been very useful.
Thank you.
And I appreciate it.
One other thing, too, to add is it's not just a static one-time evaluation. Like these patients, because they can progress. Sarcoidosis is a disease of progression.
So do you have a routine? Do you bring them back and do it like an MRI every year or something like that?
1 to 2 years, depending.
1 to 2 years. Very good.
Certainly an ECG screening and an echo.
That's wonderful. Wendy, thank you for joining us today.
Thank you.
It was great having you.
Yes,
Thank you.
Always a pleasure.